Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 192 of our Pharmacotherapy MCQ series, which majors in cardiology. And the first question reads, AJO, a 55-year-old female patient whose height is 68 inches, and who weighs 85 kg. Presents to your cardiac clinic for a cardiovascular risk assessment appointment. Her blood pressure is 145 systolic and 92 diastolic averaged over multiple readings, and heart rate is 70 beats per minute. She has no known drug or food allergies. Her pertinent labs include potassium levels of 4.2 milliequivalents per liter, a serum creatinine of 0.91 mg per deciliter, an HbA1c of 7.5%. It was previously 6.8%. Her total cholesterol is 180 mg per deciliter. Her LDL cholesterol is 120 mg per deciliter, and she has an HDL of 50 mg per deciliter. Her current medications include metformin 500 mg orally twice daily with breakfast and dinner. So my question to you is, which of the medications listed below would best be added to AJO's treatment regimen? Would it be A. aspirin 325 mg orally once daily, glipizide 5 mg orally twice daily before meals, or B. aspirin 325 mg orally once daily, atorvastatin 40 mg at night, lisinopril co-formulated with hydrochlorothiazide 10 mg / 12.5 mg in the morning, and increase metformin to 1 gram orally twice daily, or C. aspirin 81 mg orally once daily, lovastatin 40 mg at night, amlodipine 5 mg daily, and increase metformin to 1 gram orally twice daily, or would it be D. aspirin 81 mg orally once daily, atorvastatin 20 mg at night, lisinopril co-formulated with hydrochlorothiazide 10 mg / 12.5 mg in the morning, increase metformin to 1 gram orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. aspirin 81 mg orally once daily, atorvastatin 20 mg at night, lisinopril co-formulated with hydrochlorothiazide 10 mg / 12.5 mg in the morning, increase metformin to 1 gram orally twice daily. Answer D is correct because it incorporates the most appropriate primary prevention dose of aspirin, a moderate-intensity statin, and a combination of two antihypertensives, which is recommended in the most recent ACC and AHA guidelines for patients whose blood pressures are greater than 140/90 mm of mercury. This answer also provides an opportunity to increase metformin to target dose before adding an additional agent for diabetes and maximizes guideline-directed therapy. Answer C is not the best answer because it incorporates only one antihypertensive therapy and a lower potency statin for this patient. Answers B and A incorporate a higher dose of aspirin than what is recommended for primary prevention. Answer A would be improved by reducing the aspirin dose and titrating metformin as the initial therapy for diabetes. Please advance to the next question. And the next question reads, as the clinical pharmacist specialist in the cardiology team, you are requested to select the most appropriate statin for a 49-year-old male patient with no history of diabetes with a low-density lipoprotein cholesterol (LDL) of 85 mg per deciliter. He has a 10-year atherosclerotic cardiovascular disease, abbreviated as ASCVD risk score of 8%. So my question to you is, which of the following would be the best therapeutic choice? Would it be A. Simvastatin 10 mg daily, or B. Pitavastatin 2 mg daily, or C. Lovastatin 20 mg daily, or would it be D. Fluvastatin 20 mg daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Pitavastatin 2 mg daily. The 2018 update to the cholesterol guidelines suggests that patients with an LDL of 70 to 89 mg per deciliter and an ASCVD 10-year risk calculation of 7.5% or greater in patients without diabetes qualify for moderate intensity statin therapy. Moderate intensity statin therapy requires more than a 30% reduction in LDL value but less than a 50% reduction in LDL value. Of the options, answers D, C, and A reflect low-potency statin doses. Answer B, pitavastatin 2 mg daily, is associated with a 38% reduction in LDL. Please proceed to the next question. And the next question reads, AMR, a 63-year-old female patient presents to your cardiac clinic. She has a body mass index of 32 kg per meter squared with prediabetes, that is a hemoglobin A1c 6.3%. Her pertinent vitals and labs include a blood pressure of 127 systolic and 72 diastolic, total cholesterol 200 mg per deciliter, HDL of 45 mg per deciliter, and an LDL of 148 mg per deciliter. She is a never smoker. AMR prepares most meals at home, and they include regular meals of pasta, frozen vegetables, bread, red meat, and chicken. She consumes sweetened tea with 2 meals daily. AMR lacks a defined exercise program. Her 10-year atherosclerotic cardiovascular disease pooled risk calculation is 6.2%. Considering AMR's history, which of the diet plans listed below would most improve her cardiovascular, CV risk? Would it be A. restricted calorie, low-fat diet, or B. non-restricted calorie, low-carbohydrate diet, or C. restricted calorie, Mediterranean-style diet, or would it be D. non-restricted calorie, low-fat diet? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. restricted calorie, Mediterranean-style diet. Answer D is not appropriate because this patient meets the criteria for obesity, and non-restricted calories are not likely to improve cardiovascular risk factors. Answer C, studied in the PREDIMED study, improved the cardiovascular risk profile in both active treatment arms, that is nuts or olive oil. This is the best answer for this question. Answers B and A are not best because answer B does not include a reduced intake level, and answer A represents the comparator arm in the PREDIMED trial that showed no benefit. Please progress to the next question. And the next question reads, MPC, a 62-year-old female patient has just finished 6 months of diet and exercise for dyslipidemia. She has a past medical history significant for gout, diet-controlled type 2 diabetes mellitus with an HbA1c of 6.4% and asthma. Regarding her social history, she drinks 2 alcohol-containing beverages daily. Her family history is non-contributory. Her current medications include salbutamol for PRN use, lisinopril 10 mg orally once daily, and calcium 2 tablets orally once daily. Her pertinent vitals include a blood pressure of 124 systolic and 78 diastolic and a heart rate of 72 beats per minute. MPC's pooled cohort equation risk calculator estimates a 10-year atherosclerosis value of 6.8%. So my question to you is, which of the statements below is most accurate regarding the role of aspirin for primary prevention in MPC's clinical scenario? Is it A. Continue lifestyle therapy modifications and do not initiate low-dose aspirin therapy because aspirin will not benefit patients like MPC, or B. Low-dose aspirin may be indicated, though shared decision-making is important because MPC has risk factors for bleeding, or C. Low-dose aspirin is not indicated in all patients like MPC, or is it D. Low-dose aspirin is indicated in all patients like MPC? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Low-dose aspirin may be indicated, though shared decision-making is important because MPC has risk factors for bleeding. Answers A and B are incorrect because shared decision-making is important in patients 60 and older, as noted in the USPSTF aspirin guidelines for treatment decisions. Answer B, which incorporates shared decision-making and acknowledges the patient's risk of bleeding, is most appropriate. Answer D is incorrect. Although aspirin may benefit patients like the patient in this case, this would be at a cost of increased bleeding because of the patient's greater than recommended alcohol intake. Please advance to the next question. And the next question reads, KMB, a middle-aged patient desires to quit smoking. KSH smokes his first cigarette within 15 minutes of awakening each morning and smokes 15 cigarettes daily. His Fagerstrom score is 7, indicating moderate nicotine dependence. When asked to justify why he smokes, he says it keeps his mouth busy. So my question to you is, which of the therapeutic options listed below would be the most appropriate for KMB? Would it be A. Nicotine 7 mg patch, apply daily for 4 to 6 weeks, then taper, or B. Nicotine 21 mg patch, apply daily for 4 to 6 weeks, then taper, or C. Nicotine 2 mg lozenge, 1 lozenge every 1 to 2 hours for 6 weeks, then taper, or would it be D. Nicotine 4 mg lozenge, 1 lozenge every 1 to 2 hours for 6 weeks, then taper? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, nicotine 4 mg lozenge, 1 lozenge every 1 to 2 hours for 6 weeks, then taper. KMB requires his first cigarette within 15 minutes of awakening, indicating significant dependence. He will benefit from the use of lozenges to have oral activity. He should begin treatment with answer D, a 4 mg lozenge every 1 to 2 hours for 6 weeks, and then taper is correct. Answer C is not indicated because the patient smokes the first cigarette within the first hour of awakening. Answers B and A are not preferred because the patient describes mouth activity association with smoking. Please progress to the next question. And the next question reads, which of the following would be the best drug for obesity in a patient with a concomitant history of diabetes and a hemoglobin A1C of 7.8% taking metformin who wishes to augment weight loss efforts? Would it be A, naltrexone and bupropion, or B, phentermine, or C, lorcaserin, or would it be D, liraglutide? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, liraglutide. Patients with diabetes with suboptimal A1C control may benefit from dually beneficial liraglutide for lowering blood glucose values while improving weight control. Phentermine, and naltrexone and bupropion may be considered in patients with diabetes, but they do not offer augmented benefits. Lorcaserin should no longer be used and was recently recalled by the FDA due to a potentially increased risk of cancer. Answers A to C are incorrect. Please progress to the next question. And the next question reads, which of the statements listed below is most accurate regarding the role of cholesterol and lipoproteins in the development of atherosclerotic cardiovascular disease, abbreviated as ASCVD? Is it A, triglycerides, abbreviated as TG, are carried by chylomicrons and are the key component in the development of ASCVD, or B, low-density lipoprotein cholesterol, LDL, is the dominant atherogenic form of cholesterol, or C, chylomicrons and very low-density lipoprotein cholesterol, VLDL, are called non-high-density lipoprotein cholesterol, HDL, and are more atherogenic than either alone? Or is it D, apolipoprotein B, abbreviated as ApoB, is the main protein and prevents HDL from being atherogenic? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Low-density lipoprotein cholesterol, LDL, is the dominant atherogenic form of cholesterol. The dominant atherogenic form of cholesterol is LDL. Answer B is correct. Answers D, C and A are incorrect because it is LDL, not chylomicrons, and VLDL that are called non-HDL and are more atherogenic than either alone. The main protein in these is ApoB. Very low-density lipoprotein cholesterol is the chief carrier of TG, whereas chylomicrons carry dietary fat, and chylomicron atherogenicity is unknown. Please advance to the next question. And the next question reads, TPA, a 47-year-old male patient is being evaluated by his physician cardiologist at his annual wellness visit. His pertinent vitals include a blood pressure of 156 systolic and 92 diastolic, a heart rate of 79 beats per minute. His pertinent labs include a TC of 225 mg per deciliter, a TG of 195 mg per deciliter, and an HDL of 42 mg per deciliter. His basic metabolic panel and LFTs are within normal limits. He currently takes no medication. So my question to you is, which of the following is required to calculate his estimated 10-year atherosclerotic cardiovascular disease (ASCVD) risk using the pooled cohort equation? Is it A, smoking status, or B, measured low-density lipoprotein cholesterol, or C, hemoglobin A1c, or is it D, coronary artery calcium? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, smoking status. To calculate this patient's ASCVD risk using the pooled cohort equations, you must know patient's age, race, sex, blood pressure, smoking status, former, current, or non-smoker, TC, HDL, LDL, diabetes status, not current A1C value, and current medications. That makes answer A correct, and answer C incorrect. The given information to calculate the LDL is T/C minus Tg divided by 5 minus HDL is equal to LDL. A directly measured LDL is not required. That makes answer B incorrect. The CAC score was not included in the pooled cohort equations. That makes answer D incorrect. Please advance to the next question. And the next question reads, TNA, a 64-year-old female patient presents to your cardiology clinic for routine follow-up. She has a past medical history significant for stroke, hypertension. She had a non-street segment elevation myocardial infarction 4 months ago. Back then, TNA's LDL was 148 mg per deciliter. The cardiologist initiated her on atorvastatin 80 mg orally at night. On recheck, TNA's LDL is 76 mg per deciliter. So my question to you is, which of the following would be the best therapeutic plan regarding TNA's treatment? Would it be A, no further therapy is indicated, given the patient's risk profile, or B, add ezetimibe, or C, add evolocumab, or would it be D, add cholestyramine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, add ezetimibe. This patient is considered at very high risk of future atherosclerotic cardiovascular disease (ASCVD) events, given her age, older than 65, hypertension history, and history of 2 major ASCVD events. Therefore, her goal LDL is less than 70 mg per deciliter. That makes answer A incorrect. Both ezetimibe and PCSK9 inhibitors have outcomes data for their use, but PCSK9 inhibitors are considered of lower value, according to cost-effectiveness analyses. That makes answer C incorrect. Furthermore, with an average LDL lowering of around 10% with the addition of ezetimibe, she will likely achieve this goal with ezetimibe. That makes answer B correct. Cholestyramine is not indicated here, which makes answer D incorrect. Please advance to the next question. And the next question reads, TNT, a 27-year-old patient has severe hypercholesterolemia on maximally tolerated statin therapy and ezetimibe. The patient's pertinent labs include an LDL 125 mg per deciliter, down from a baseline of 195 mg per deciliter, and a TG 230 mg per deciliter. Basing on the 2018 guideline on the management of blood cholesterol, which of the recommendations listed below would be most appropriate for TNT's clinical scenario now? Would it be A. Add fish oil supplements, or B. Add niacin extended release, or C. Add a bile acid sequestrant, or would it be D. Add a PCSK9 inhibitor? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Add a bile acid sequestrant. A bile acid sequestrant is indicated in patients 20 to 75 years old with severe hypercholesterolemia who achieve less than a 50% LDL reduction despite a maximally tolerated statin and ezetimibe, as long as the patient's TG values are less than 300 mg per deciliter. That makes answer C correct. A PCSK9 inhibitor has uncertain value in this patient population, but may be considered in patients older than 30. That makes answer D incorrect. Many clinical trials have shown a lack of clinical benefit of niacin or fish oil in patients for primary prevention, and these are not recommended in the ACC 2018 cholesterol management guidelines. That makes answers B and A incorrect. Please proceed to the next question. And the next question reads, QPA, a 48-year-old male patient presents to your cardiology clinic for follow-up. Her past medical history is significant for hypertension and she is on lisinopril. She has an estimated 10-year atherosclerotic cardiovascular disease (ASCVD) risk of 11%. Her pertinent labs include a total cholesterol levels of 220 mg per deciliter, an HDL of 55 mg per deciliter, and a TG of 622 mg per deciliter. She currently takes no medications. Apart from looking for a reversible cause, which of the following would be the best next step in managing QPA's cholesterol according to the American College of Cardiology (ACC) 2018 guideline on the management of blood cholesterol? Would it be A. Initiate a statin and niacin, or B. Initiate a statin and fish oil, or C. Initiate a statin and fibrate, or would it be D. Initiate a statin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Initiate a statin. In adults with severe hypertriglyceridemia (TG greater than 500 mg per deciliter), the first-line therapy is a statin while identifying and correcting any reversible causes of elevated TG, which makes answer D correct. Only when TG values are persistently elevated, especially above 1000 mg per deciliter, despite initiation of a statin, treatment of secondary causes, and management with diet, is a fibrate recommended. That makes answer C incorrect. Adding niacin or fish oil for elevated TG values was not recommended in the ACC 2018 guidelines. That makes answers B and A incorrect. However, in the REDUCE-IT trial, enrolling patients with clinical ASCVD and elevated TG, that is 150 to 499 mg per deciliter, showed the benefit of icosapent ethyl, which may be reflected in the future guidelines. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 193.